Menstruation is, I think, like an orchestra. There are all different aspects of your body playing a role. Your brain is sending a hormonal trigger to your pituitary gland, and then the hormones from the pituitary are then signaling your ovary. It's this incredible symphony.
Dr. Jen Gunter is a gynecologist, a physician, and the author of 2 New York Times best-selling books. On today's episode, she shares her insights from her new book, Blood.
And that's one of the big problems, because when we don't talk about it and people don't know what's normal, then they don't know what abnormal is. And the reason this is so critical, if you look at the incidence of iron deficiency, 40% of women ages 22 and younger are iron deficient. Polycystic ovarian syndrome affects about 10% of women.
All of the factors it's associated with are very much linked with diet. High blood pressure, insulin resistance, obesity, high cholesterol.
Joining me as co-host today is Dr. Sarah Berry. Sarah is a world leader in large-scale human nutritional studies that can help us learn about women's health. She's an associate professor in nutrition at King's College London and chief scientist here at Zoe.
It's either been the butt of jokes or it's been something people have spoken about as if it's bad or disgusting or polluted.
What's the biggest misconception people have about menstruation?
Having heavy bleeding is normal. It's something that people should just suck up or suffer. If the pain is interfering with your activities of daily living, then it should be evaluated.
Welcome to Zoe, Science and Nutrition, where world-leading scientists explain how their research can improve your health. Jen, thank you for joining us today.
Oh, thank you so much for having me.
It's a real pleasure. Now, we have a tradition here at Zoe where we always start with a quick fire round of questions, and we have very strict rules. You can say yes or no, or if you have to, you can give us a one-sentence answer. Are you willing to give it a go?
All right, I'll do my best.
All right. Can a person have over 400 periods in a lifetime?
Yes.
Does your period always have to be a negative experience?
No.
Is PMS inevitable?
No.
Can menstrual cramps be as strong as the experience of giving birth?
Yes.
Wow. Can tampon use lead to endometriosis?
No.
Brilliant. You see, that was quite easy. Final question, and you can have a whole sentence for this.
Oh, you're lucky.
What's the most surprising thing that you've learned about periods in writing your new book?
How impactful the culture of shame has been for centuries and centuries, so much so that even in their own personal journals, women couldn't write about their menstrual experience.
As someone running a company that does a lot of data science, here's something that fascinates me. YouTube has been telling me that 69.3% of you who watch this channel frequently haven't yet hit the subscribe button. So let's make a deal. We'll keep creating this show and do everything we can to make it better and better each week. All I ask in return is that you hit the subscribe button. Thank you. I like to start these chats off with a bit of personal connection to the topic, but I can't sit here and pretend that I know what it's like to menstruate.
But I think the thing is, even for women like myself who have menstruated or aren't menstruating anymore, I still feel I know almost nothing about menstruation, because just like menopause, it wasn't talked about. It was something that we were a bit embarrassed in our household to talk about. It was something that then when my period first started, I really struggled. I struggled because I felt a bit unclean. I felt a bit smelly. I felt embarrassed even to talk to my own mum about it, even though she was quite an open person. And I think as a mother of a 14-year-old, I'm really hopeful that I'm going to learn some things from you that will help me guide me to be, do this better with my own daughter.
I think that's a really common experience, that just people have not talked about menstruation in an open, non-sophomoric way. It's either been the butt of jokes or it's been something people have spoken about as if it's bad or disgusting or polluted. And we have centuries and centuries of history making people feel that way. And I think we're now starting to see a little bit of change, and that's really positive. And I think the biggest step is just talking about it openly, like it's no big deal. It's a body function.
I would love you to educate me and our listeners on the basics, because even though I have menstruated for many years, I think there's so much I don't know just because we don't talk about it.
Yeah, I think that it's one of those things that, I menstruated for many years. I'm team menopause now. But people think that they know about it because they're experiencing it. But if you're not taught about the biology, then you don't actually know kind of what's going on behind the scenes, as it were.
And Jen, can I start right at the beginning why do people menstruate?
Menstruation is a byproduct of the menstrual cycle. And the menstrual cycle is the best way for us to have a pregnancy as humans. So most animals have estrus, and we have a menstrual cycle. And there's only, the menstrual cycle has evolved 5 different times, or there's 5 different species that menstruate. It's evolved 4 different times. Us and the great apes, or some apes, there's some bats, there's the spiny mouse, and the elephant shrew. So it's sort of a very eclectic group.
We're in a very small, I didn't remember, a very small group is what you're saying.
It's a very small group of menstruators, and it's almost sort of like, punk rock names or something, right? The menstruators, and here's the bass player, and people always say, well, what about dogs? And they have estrus. Their bleeding actually is from the vagina. It's not from the uterus. So, yeah.
I know that.
So the menstrual cycle is a byproduct of having a very, very thick uterine lining, very thick, specialized uterine lining. And with human embryos especially, we have the thickest lining, humans. Human embryos are incredibly invasive. They're basically like a cancer. They're going through the uterus. They want to get oxygen. They want to contact maternal blood vessels. That's how you grow big brains. That's how all the things that sort of make us human. And so you have to have basically, a catcher's mitt, a backstop to kind of handle that invasiveness. And there are situations where that goes awry and you can get placenta percreta, where actually the placenta implants on organs in the body. And that's actually a very dangerous, catastrophic situation. So part of it is to handle the invasiveness. Part of it is as a fitness test for the embryo. You've got to make the embryo work for it to get to the blood vessels. And finally, the human endometrium also acts like a biosensor for embryo quality. And so if the embryo has significant chromosomal abnormalities, significant abnormalities, it triggers this inflammatory response and out with the menstruation.
You're explaining why you might want to have this thick uterus lining. Why doesn't it just stay there for 30 years rather than have sort of come in and out? So I'm still confused about that.
That's a good question.
Yeah, it's a great question. Because you build that uterine lining up each month with exposure to successively higher and higher levels of hormones. And you need to have a new, basically a fresh start each cycle to do that. You can't, because the endometrium has undergone this irreversible change called decidulization, you can't now build new endometrium on top of that. And the tissue can only be decidulized and hold in that sort of perfect sort of environment, if you will, for a very short period of time. Because also what happens is the progesterone that produces this change, this decidulization, comes from the corpus luteum, which is sort of like the eggshell left over from ovulation. And that has a time limit. It can only produce progesterone for, 12, 14 days. And so when the corpus luteum basically runs out of gas and stops producing progesterone, it's the withdrawal of progesterone that triggers the bleeding. And then the uterine lining comes out, and then you start anew, and the cycle begins again. But with animals with estrus, so with humans, decidulization is triggered by ovulation.
So you said decidulization?
Yeah,
again?
decidulization. So that's the change in the uterine lining that prepares the uterus for implantation. So this thickened, specialized lining we call the decidua. And that's triggered by a progesterone released with ovulation. So for humans, that specialized uterine lining is there waiting for the endometrium. But with the estrus cycle, that trigger comes with implantation. So you don't have that specialized lining waiting. So if pregnancy doesn't happen, there's very little there and the body can reabsorb it.
So you're saying that almost all other animals, they don't have to do this special thing, so it can just sit there all the time until you get the start of pregnancy, and then it starts to make these changes.
Exactly.
And Jade, could you just talk through then the next bit actually, which is you've got this thick lining coming through to explain menstruation. What's actually going on there over what time, and what could you just again explain what's sort of going on inside the uterus to people like me who don't really understand it?
So the start of the menstrual cycle actually is with the start of menstruation. So that's because you have to time it with something that is, reproducible and that you can ask people when the start of their cycle is. So we consider that day 1. And what happens is there's follicles, which are immature eggs, that have been recruited by the hormones in the brain. And there's a leading follicle that develops. And the follicles produce estrogen. And it's the estrogen that gets the uterine lining ready. And so in the first part of the menstrual cycle, we call that the follicular phase. And the lining's getting thicker and thicker and kind of getting ready. And then once this dominant follicle has sort of reached a critical point, there are signaling from the brain, or there is signaling from the brain that triggers ovulation. You get exposure to progesterone, and now that's the luteal phase, the second part of the cycle. And it's during this second part that the endometrium undergoes this irreversible change and becomes what we call the decidua. If pregnancy doesn't happen, the corpus luteum runs out of progesterone, and that withdrawal of progesterone triggers all kinds of chemical reactions that cause the top layer of the endometrium, the decidua, to peel off. That opens blood vessels, and now you get bleeding from the arteries and the veins. That pushes.
Which is what's underneath this layer that's
Right.
come off. So there's two things happening. Is that right? You're saying there's this layer that comes off and then there's bleeding
Right.
as it comes off.
And that's where the blood comes from. So the blood is just from the arteries in the uterus. It's not like special menstrual blood. It's got this, the same amount of hormones as in your, if you drew a sample from your vein, it's the same. And so you have the bleeding that pushes the lining out. You have release of all these inflammatory mediators to get the decidua out, to push that top layer of the endometrium out. And then what happens is you've got then a next follicle coming up, and you start getting exposure to estrogen. You get new endometrium being built, and that helps to stop the bleeding, the spasms in the uterus, the contractions, which are created by prostaglandins and other chemicals, squeeze off the blood vessels so they can clot and start again. And that's the coolest thing I think about menstruation is it's the only scarless healing in the human body. But you'll get clots, the blood will clot. You shouldn't have clots that are bigger than the size of a quarter or a 50-cent piece. Or if you do, that would be a time to talk. If you are soaking through your menstrual products onto your clothes, if you're having to change pads or tampons every 1 to 2 hours for, more than just kind of once. So if you have to do that, or if when you stand up, you have a feeling of gushing. So all of those things can be signs of heavy periods. Sometimes they're not, but you don't know. But those would be all the signs that would say, you should probably see your doctor and be investigated. And the reason this is so critical is if you look at the incidence of iron deficiency, it is very high amongst young women. And in the United States, the study I'm referencing is from the US, so I don't know if the data is the same in other countries. 40% of women ages 22 and younger are iron deficient.
Yeah, it's similar prevalence in the UK.
Yeah.
40% under 22, did you say, are iron deficient? That's extraordinary.
It is, and it's often dismissed because people can have iron deficiency and not have anemia. And often people are told if they don't have anemia, they don't need to worry about it, but that is incorrect. And iron deficiency itself is a medical condition with consequences.
So how many mils on average, as a scientist, I always like data. How many mils on average would a person that's menstruating lose during a menstrual period?
So it's about 80 milliliters. Which doesn't seem that much.
Wow.
Yeah.
It doesn't.
But there's also cervical discharge and vaginal discharge. And so the amount that comes out may actually be larger. There's also the decidua, which is kind of the lining, which isn't counted in that. So the actual blood comes from tests where they do, radio labeled stuff and to see, how much blood has been lost. So the actual blood itself is 80 milliliters, but it may seem like more than that.
Okay, so you might have double the amount actually coming out, but it's mixed with, other fluids and other tissue.
Yeah. So all the studies that look at the actual volume of blood, they're either weighing pads or they're actually doing these sort of radio labeled blood samples to try to figure out like how much has, been lost. And so we say 80 milliliters, understanding that for some people that might look, it may be more than that based on the amount of discharge and, other things that are going on.
So Jen, having explained that really well, and thank you, and I've already learned a lot, and it sounds like Sarah's learned something as well already. What's the biggest misconception that you find people have about menstruation?
One is that having heavy bleeding is normal. It's something that people should just suck up or suffer. And again, we have this sort of epidemic of iron deficiency amongst, young people, which is, really not acceptable. I think that that if you have a lot of pain, that's normal and you should suck it up. And, there's sort of this dichotomy of either, people saying, oh, women are able to tolerate more pain, or they're complainers. It's sort of like, I always say being a woman is like walking on the edge of a knife. You're either too much in one or too much in the other, right? You know exactly what I mean. And so there's that. And so people who have terribly painful periods get untreated and they don't get investigated. So
lots of pain is not just normal for everyone to have to experience?
Well, I would tell people that if the pain is interfering with your activities of daily living, then it should be evaluated. I think that, there are some people who have minimal cramping and don't have much, and there's other people who are at the other end of the spectrum, and there's people everywhere in between. And unfortunately, pain is a byproduct of menstruation. That's how, it takes uterine contractions to get the blood out. It takes uterine contractions to stop the bleeding. And so that is part of it. But for some people, it can be very painful.
And Jen, just to understand that, actually, I just want to make sure I understand. Is that what is causing the pain around the time of your period?
So the uterine contractions are a big part of it. They can be quite intense. As we sort of talked about in the rapid fire, the intensity of the pressure can be the same as in the second stage of labor, which is when you're pushing. You're talking 120 millimeters of mercury. That it's a lot of pressure. Like, when you blow up a blood pressure cuff, you're blowing it up more than 120 millimeters of mercury, sort of for that. And that's quite uncomfortable, right? When you're getting your blood pressure checked and then it goes down, you're like, okay, that's better.
And why is your body doing this?
Well, one, to get the lining of the uterus out, so the contractions help move things along. Also to squeeze blood vessels, right? So, when you're bleeding, you put pressure on something, so it's actually applying pressure.
So your body is both. It's a bit like you're saying there, it is a little bit like delivering a baby, like it's squeezing this out.
It's pushing things out.
And then it's compressed. It's doing its own sort of tourniquet on the inside to shut down the bleeding.
Yeah, and then that reduces blood flow to the uterus. So there also is probably pain related to ischemia or low blood flow. Prostaglandins, which are released, which are hormones that are sort of produced locally at the site of injury or inflammation, those cause pain. And so there's other inflammatory chemicals that are also probably contributing as well. And some people who have more pain, they may have stronger contractions. They may have uncoordinated contractions, so that might be more painful. Or they may have heavier bleeding, and that can be part of it. Or they could have a medical condition that's, contributing to pain, like endometriosis. There are people who have, very minimal cramps and like, yeah, it's a nuisance, but I can deal with it. And there's people who are, really debilitated.
But I think that's a really important point, because I remember when I was at school, there would be a few girls that would have to take 3 or 4 days off a month because of how debilitating their cramps were. But again, because it was a taboo subject and we didn't really talk about it, there was a kind of feeling I got from the adults in the school was, oh, they should suck it up,
right.
We all get cramps. It's just part of the deal. Really important point for people to be able to acknowledge that it is worse. It's really physiologically worse. It's not just that someone's not sucking it up and other people are, are better at handling it. And it's because it's such a taboo topic that, we don't talk in this way. Why do you think it is such a taboo topic?
Since the beginning of Western medicine and in many religions, menstruation has been, viewed as being toxic, being a sign of women being inferior to men. If you look at the sort of ancient Hellenic medicine, it's, was a sign that, men were in perfect balance and women were not. And every cell in a woman's body was overly moist. I hate that word, moist. And, the way they dealt with their extra moisture was menstruation. So if your worldview is, men are perfect and women are inferior, you can make anything fit that, you can find whatever, physical quality and say, oh, well, that's proof. And so, and then you have religions talking about, menstruation being dirty, polluting. You have cultures where women have been excluded from religious services, where they aren't allowed to prepare food in their own kitchens, where they're sent out to menstrual huts where, crops failing was blamed on menstruation. So there are many sort of patriarchal cultures where, menstruation has been viewed as sort of this convenient scapegoat.
In 2022, we took a huge risk. We put our reputation on the line to prove that Zoe membership could improve the health of millions. Our team commissioned a randomized controlled trial. It's the most rigorous test that science has to offer, which means you commit to sharing your findings, good or bad. The results of this study have just been published in Nature Medicine, which is basically the Oscars of the science world. And these results show Zoe to be more effective in improving health than government advice. Participants doing Zoe saw larger reductions in blood fat, body weight, and waist size. They had better blood sugar control and saw an increase in their good bacteria. Crucially, those doing Zoe also felt better. They were twice as likely to report improved mood and feeling less hungry, and 4 times more likely to report better sleep and more energy compared with the control group. Results like these are why more than 100,000 members trust Zoe to help them make smarter food choices each day to achieve their health goals. So, will you give Zoe a try? The first step is easy. Take our free quiz to find out what Zoe membership could do for you. Simply go to zoe.com/podcast. Okay, back to the show. I'd love actually to come to some of the things you talk about in the book, and particularly talk about this idea of like a superhighway in the brain in the book. I'd love actually if you could help us to understand like why you're saying understanding this superhighway could be the key to understanding what's happening in the body during menstruation. And you use this word brain-ovary connection, which I definitely haven't heard of before. What is it?
Well, I made up that term, so it's been here before. So, menstruation is, I think, like an orchestra. There are all different aspects of your body playing a role. And you have an area deep inside your brain called the hypothalamus, which is sending a hormonal trigger to your pituitary gland. So both of these are in your brain. So that's the brain component. And then the hormones from the pituitary are then signaling your ovary. And it's sort of this sort of symphony between these 3, players that are, kind of the hormonal trigger behind getting a follicle to develop, getting the ovulation to happen, getting the production of estrogen. And at the same time, all the hormones that are produced from the developing follicle, those are then being relayed back to the brain. So there can be these fine-tune adjustments. So once you get to the right level, then another thing happens, and it's this sort of incredible sort of orchestrated event. And
these are affecting sort of the hormones that we often talk about, like estrogen and progesterone. These are being controlled by this sort of symphony you're describing.
Yeah. So you get pulses of a hormone called GnRH from the hypothalamus that sort of trigger the pituitary. And the pituitary releases a hormone called follicle stimulating hormone. And what that does is there's sort of a group of follicles of eggs each month or each cycle that are capable of ovulating. Those are they've been given a VIP ticket, but they haven't got in the club yet.
Okay. They're in the short queue at this point.
Yeah, they're
the
short queue because it's taken about 300 days for those follicles to get ready for the VIP line. So, because there's this whole sort of incredible journey in the ovary that happens up to that point. So these follicles have been given a VIP ticket and they're ready. The hormone FSH is released, and it's kind of like the bouncer. It sort of picks who gets to come in. And then a few follicles start developing. And then the estrogen that's being produced is going back and forth and communicating with the pituitary. And then once you get to a certain level, then the hormonal signals change and you get the trigger for ovulation. You get this surge of a hormone called luteinizing hormone. And that's where you get ovulation, and then you get the egg released. So it starts its journey through the fallopian tube, or oviduct that we like to call it now. And then the leftover part of the follicle, which is sort of like the shell, that's what organizes and starts to produce the progesterone.
So there's this continued kind of bidirectional feedback going on involving the brain, which I again, it's totally new to me.
It's this incredible symphony that's happening. And once you have a basic understanding of it, a basic understanding of, okay, well, then it's the prostaglandins that are contributing to pain. So for example, we know that pain with menstruation is far less likely to occur when people don't have what we call an ovulatory cycle. So you can menstruate and not have ovulation. So it's ovulation that is what produces the prostaglandins. So if you know that, well, if it's prostaglandins that cause pain, then I can take medications that block prostaglandins like ibuprofen or naproxen. You can take those, and they're very effective for many people at treating pain.
Jen, what role does diet play in this whole connection this symphony that you're describing?
Well, We haven't really determined that there's an optimal diet for menstruation or for the menstrual cycle. And so we really say that it's, the typical, the diet that's good for your heart, the diet that's good for your brain is the diet that's good for your body. And if you think about humans, they are incredible omnivores. And people, if there were a superior diet for the menstrual cycle, then we would have seen places in the world where people couldn't reproduce as much, right? But if you think about the ancestral people in Greenland versus the ancestral people in Greece or the ancestral people in Australia, they would have all had incredibly different diets, and yet they all reproduced and they all had populations that grew.
And what about appetite? Because I think, again, growing up, I know that some people say, oh, I'm really craving this at this time of my cycle. And I think there's some evidence coming out now, particularly because how you've described that the brain is so involved in this. I wonder if there's anything you can expand on related to appetite.
There's a little bit more calorie requirement. In addition,
and that's in the second half.
In the second half, right? And whether that's related to sort of preparation for pregnancy, the extra tissue that's required to build, all those types of things. And definitely lots of people have food cravings in the second half of their cycle, in the luteal phase, and that can be really significant for some people, can be less so for others, and sometimes that's folded into kind of the whole PMS, premenstrual syndrome kind of complex, or premenstrual symptoms. And definitely there seems to be a craving for carbohydrates. That seems to be kind of a pretty universal thing. And also chocolate is a pretty universal thing too. Whether that's a true biological need versus, chocolate makes people feel good, it's kind of hard to know. Are people craving something because it's a time where they don't feel as well, and chocolate makes me feel good when I have some, So it's hard to know. But yeah, so there is, a slight increase in the calorie requirement, and definitely people have some food cravings, and carbohydrates tend to be the ones that are listed most in that. And I'm not sure that, we have a biological explanation. The hormone progesterone may be part of that. But I don't think we have a good answer.
We had a question that came up a lot from our listeners, which is, I think something you also touch in the book about what role, if any, does stress play in this connection between this, these parts of the brain and then on.
Yeah, well, so stress isn't good for anything. I mean, that's kind of the blanket answer, but yeah, absolutely. So people have really tried to understand this connection between stress and the menstrual cycle, and it's a hard thing to study because people often also change their eating habits when they're stressed. People have tried to look at it, for example, in context of war, which is incredibly stressful, but there's also often calorie restriction during that time, right? So it's very hard to tease out, and people aren't keeping a food journal when they're going through an incredible stressful event. So how do you know? So what we think is it probably requires a pretty significant amount of stress to have an impact, but it wouldn't necessarily have to be like a single massive stressful event. It could also be a daily chronic stress, like a bad employer, that type of thing. Or perhaps, a bad, home relationship. And for some people, then that can have an effect on the menstrual cycle and can actually stop menstruation.
Okay, so it's not a myth that stress can stop you having your period, stop you menstruating.
It's not a myth, but I think it's important that for a lot of women, I think have sort of been dismissing, oh, well, you were just studying for an exam. So it's generally not that level of stress. It would be kind of more of a significant stressor. And if you think about, and many people are under significant stressors, then if you think about it from an evolutionary standpoint, if there's, food, if you don't have enough food, if there's a massive sort of environmental catastrophe, that's probably not the best time to reproduce, right? So it kind of makes sense that there's these fail-safes in there to sort of, not put that massive biological investment of reproducing in a time where it may not be likely to succeed. So you can understand that there's sort of an evolutionary basis to it. But because stress can, again, have impact on calories, and we know calorie restriction absolutely can shut the menstrual cycle down. So, we have to kind of sort all those things out.
I'd like to ask about PMS. We had a lot of questions around that. And I think you've touched a part on this, but could you just explain a bit more? What is it? Does it involve this brain that you're describing as well? And also sort of how prevalent is it? How does it present always in the same way to anyone who's listening to this for themselves or someone they love? So premenstrual symptoms or premenstrual syndrome, and then the more severe form, premenstrual dysphoric disorder, PMDD, are
are sort of a collection of symptoms that are associated with exposure to progesterone. So they can't happen in the first part of the cycle. So if people are having these symptoms before they ovulate, then it's not PMS or PMDD. It may be a different diagnosis. And so that's one of the situations where keeping sort of a menstrual calendar for 2 or 3 cycles can be useful, because sometimes people can have depression, and depression can be worse with hormonal changes. And so you want to know, is it that, or is it PMS, PMDD? And PMS is the collection of symptoms that, might include like bloating or fatigue or headache, irritability, food cravings. Those are very common symptoms. And if you look at the broader collection of symptoms, it can affect 70 to 80% of women. Some people are more severely affected than others. If you're looking at PMDD, it's much less common, but it's much more severe, and people can have really profound depression, really profound mental health changes during the second half of their cycle. Some people can even have, suicidal tendencies. And so that's, obviously requires treatment. And obviously, the more severe, the more, the more we want to offer treatment. But so that's kind of the spectrum. The actual cause, I think that we don't quite understand. We do know that because it has to happen after ovulation, that exposure to progesterone is clearly part of it. But there's all kinds of other chemicals, in your brain that are, can be affected as well. And since antidepressants can be very effective, obviously, there's, involvement, obviously, of serotonin or norepinephrine or dopamine. But I don't think we truly understand at a brain chemistry level what's going on.
And just for me to understand, because you talked before about some of the pain that's going to happen while you're actually having your period, but the symptoms you're talking about here are not really related to that. Is that right? And
yeah, that's correct. So people can have PMS and not really have menstrual cramps. So there's sort of this other collection of symptoms. And people can have terrible menstrual cramps and never have any food cravings. And that's part of the complexities of the experience. And this is, I think a really important why it's, again, important to have the discussions, because people sometimes think they're abnormal if they have the symptoms or if they don't have the symptoms. Many women who have PMDD, the very severe form, have been written off and been told that they're crazy or told that they're too hormonal. All these awful things have been told to them. And, they have a real diagnosis and a condition that has treatment, and that's terrible, right? That's part of the culture of shame of if you don't know that this is a medical condition and you've been dismissed by your providers, you could start to think, my gosh, like, am I going crazy? Like, what is going on? Everybody's telling me there's nothing wrong with me, but there actually is. You actually have a medical condition.
And Jen, how long would be, again, trying to get to like the facts behind this, how long a period would, like, on average, someone who's having these PMS symptoms experience them? Is that for like the full 2 weeks of the second half of the cycle, or what's sort of normal?
So it can vary. So some people might just have symptoms the last few days. Some people may have it for the full 2 weeks. Some people might have it for 7 to 10 days. I think that as, it gets more severe, so severity can be not just the intensity of the symptoms, but the length of the time of the symptoms. So if you have pretty disabling symptoms, but you have them 5 days a month or 5 days a cycle, you have 25 days to recover in between. If you have them for 14 days, then you might only have 14 days to recover in between, right? Or 12 days if you have a shorter cycle. And that doesn't mean that people who have, 5 days of symptoms shouldn't be offered treatment. They absolutely should. But when you start to think about how then it can kind of carry over, when it starts to, if you're having like basically 50% of your life affected by these symptoms, that can be pretty dramatic for people. But some people can be really affected even just for 2 or 3 days. And so that's, again, why it's important to talk about it and to be able to offer people treatment.
And for people on contraception, or whether it's oral or IUD, do they still experience PMS?
The estrogen-containing birth control pill can be very effective at treating both PMS and PMDD. It won't take away, people may still have food cravings or other types of things. And obviously it doesn't work for everybody because not all therapy is 100% effective. But stopping ovulation, which stops that sort of cyclic release of the progesterone and the change in hormone levels. So giving people constant hormone levels seems to be an effective treatment for many, which tells us it's less about the levels and more about the change in levels that matter, the ups and downs, can be very effective treatment. But with a hormonal IUD, you're still ovulating. So you're not taking away any of those triggers. So people can still have those symptoms, absolutely. And again, I want to point out that the birth control pill may not work for everybody. So someone might say, well, I'm taking it, I still have symptoms. And yeah, I mean, not every medication works for everything.
Interesting. And there's also certain diseases that I know we think about when we think about menstruation. So one of these, again, I think that isn't talked about a lot is PCOS, so polycystic ovarian syndrome. But actually, it's really prevalent. I would be great if you could explain what it is, how prevalent it is, and let us understand it a little bit better.
Yeah, so polycystic ovarian syndrome affects about 10% of women. And that makes it the most common endocrine disorder among women of reproductive age. So there isn't another hormonal condition that affects 10% in medicine is a pretty staggering amount. And it's a very medically complex thing that is, we should suspect when people have a regular menstruation, when they have a regular ovulation, and they have evidence of increased male, what we classically call male hormones, androgens. So they may have increased acne, they have increased hair growth on their chin. They in severe forms, they could even have some hair loss on their head.
What is this? What's going on?
Basically, what is happening is during the development of the follicles, so I alluded to this earlier, there's about a 300-day journey. So when you're born, you have all your follicles are dormant. They're completely asleep. And to get to the stage where they can accept the VIP ticket that we talked about, that's about a 300-day journey. That's happened. And we understand very little about that. And for people,
there's like all this maturing that's going on that we don't even think of this egg long before it starts the journey that I learned about in school or whatever, where it sort of starts wandering down this tube.
Exactly.
It's not just sitting there ready, which is sort of, I think, what I got
Yeah,
taught.
I think people think it's like they're asleep and then boom, they're ready for the VIP ticket. But just like going to any club, it takes you time to get ready, right? So it's a 300-day getting ready journey.
I will not comment in this room on that.
Oh, well, I get ready in 5 minutes. I'm sure you do, Jen, as well.
Well, I think the older you get, the less time it takes to get ready. I don't think I'm going to study that, though. So somewhere along in that development process, there is a glitch. But we don't really know, is that the trigger or is the trigger from something else? So what we're seeing is that these follicles are not quite getting to the point where they should be able to accept ovulation. They are, filling with fluid. There's hormonal imbalances in the production from the follicles. Then we also have many people have insulin resistance as well associated with polycystic ovarian syndrome, and that also contributes. And there's increased inflammation as well. And so it's sort of, we don't really know the chicken or the egg here, is the disturbance of ovulation the cause or the result, right? Is the insulin resistance the cause or the result? Is the inflammation the cause or the result? Or are we actually looking at a couple of different conditions that we're lumping together because they present in the same way? And so in a nutshell, that's kind of polycystic ovarian syndrome. And it's a really important thing to know about because not only does it cause irregular periods, which can obviously also affect fertility for people, but it is associated with an increased risk of metabolic syndrome and then also type 2 diabetes. It's associated with an increased risk of endometrial cancer. It's associated with an increased risk of depression and suicide. And there's many other, an increased incidence of fatty livers. So there's many other serious health increased risk of hypertension and cardiovascular disease. So there's all these other serious health implications of polycystic ovarian syndrome. So you should really think of it as sort of like a system-wide condition, not just sort of an ovulation problem.
Yeah, it's interesting. All of the factors it's associated with are very much linked with diet. High blood pressure, insulin resistance, obesity, high cholesterol, etc. that's linked with this. And so I guess it's a time that we have to be really, really mindful of the food that we're eating as well. So for individuals who have PCOS.
The interaction with obesity is not a cause of polycystic ovarian syndrome at all. What it is something that can make the symptoms much worse. And so when we look at at all populations, the incidence of PCOS is the same, whether someone is obese or not. But people who are obese have worse symptoms. So when we look at study populations, they're overrepresented because who's more likely to come to a PCOS clinic? Somebody who has worse symptoms.
Okay, interesting.
So that's kind of has a bidirectional problem. So first of all, if you tell people it's all related to your weight, then that's wrong. And their symptoms may be partially related to it, but that makes people, they feel dismissed. But then what happens is people who aren't obese are told they can't possibly have polycystic ovarian syndrome because they're not overweight. And so they then don't get the care that they need. So, the interaction with obesity is, probably related in part to the worsening of insulin resistance. That's a component of PCOS. Worsening of the inflammation. That's part of PCOS. And so many symptoms can be improved with weight loss for some people. But it's also important for people to know that there are other treatments as well, and to understand that many people, it's very challenging. Losing weight is challenging. Many people have been dismissed because of fat phobia in the doctor's office. So we have to be very, very mindful of that and, offer therapies independent of that.
Jen, I'd love to move now for all of our listeners who've been listening to this, understanding it, switching now really to more actionable advice for them. So I guess maybe starting with PMS, where you described how many people, I think you said 70 or 80% of women can be experiencing this, and we had a lot of questions. Is there anything they can do about it?
Yeah. So first of all, for many people, mood symptoms can improve with exercise. Now, obviously, that's not the only thing we offer to people. And certainly, if I was feeling poorly and my doctor just said, oh, well, you just need to exercise more, I would probably have felt very put off. So I always like to say that that's not something that should just be offered as a standalone treatment. But almost every medical condition improves with exercise. And we've seen some really recent great data on the impact of exercise on mood from a beneficial standpoint. So that's one option to think about. Certainly, when people are really suffering with PMS, they're hormonal birth control pills that take away those hormonal fluctuations. And also antidepressants can be very effective when people are, especially with the mood-based symptoms that are the worst. And the interesting thing with the antidepressants is you can just take them for the period of time that you have your symptoms. And so that doesn't mean you have to take them the whole cycle. So if you just have bad symptoms for 10 days a month, you can take them for 10 days.
Okay, it's not one of these, because I think often I was under the impression this is something you have to take for months and months before it starts to have effect.
No,
but this is
not at all.
Wrong.
So you can take them so now that's not always easy for people to manage. It's not intuitive to say, oh, I'm going to take them for just 10 days every cycle and I've got to wait. And then you think, oh, is that my PMS, or am I just feeling irritable because my boss was mean to me today? You don't know, right? So it can be hard. So some people decide to take it every day because it's easier. Some people decide just to take it, when they're ovulating, if they know. So then they've kind of covered the second half of the cycle. And other people decide to take it when they have the start of their symptoms. And so those are some different strategies depending, again, on the severity of symptoms. I also think it's great for people to have a good, healthy foundational diet. But also not to beat themselves up if they feel that having chocolate for 2 or 3 days of the month makes the month much more bearable, then great.
Our data says that the dark chocolate is pretty good. So it's about switching the type of chocolate potentially rather than having to give up.
I know. I was thinking that should be part of a government allotment that we all get our good quality chocolate every month.
I love that. We'll start campaigning on that. I think that's a brilliant worldwide campaign.
I think so.
And Jen, what about menstrual cramps? So you said some people have them as strong as if you're actually having birth contractions.
Yeah.
What can we do to counterbalance that?
So ibuprofen, non-steroidal anti-inflammatory drugs, naproxen, and even starting them a day before, if you have an idea when your period is going to start. So they can be very effective at reducing menstrual cramps. I think it's important to point out that if those don't work, it could be because you have something else going on, like endometriosis, which is a condition where tissue very similar to the lining of the uterus is growing outside in the pelvic cavity. But also, I think it's about 10% of people that these drugs just don't work for them. So it's just kind of, they don't help. Then all of the hormonal methods of birth control can be very effective. And so a hormonal IUD the birth control pill, the Nexplanon implant, the Depo-Provera injection. Those are all very effective ways, and they work by one. The implant, the injection, and the pills work because they stop ovulation, but also there's a hormone in them called progestin, which is a synthetic form of progesterone. And progestin keeps the lining of the uterus very, very thin. So when there's less lining to come out, there tends to also be less cramping. So, and you can take these medications every single day so you don't even get a period. So that's also an advantage.
Yeah, and it's interesting because the hot topics amongst many of my friends who are in their late 40s is either menopause or thinking about their children who are having quite extreme symptoms, some of them. And something I know they would be desperate for me to ask you while you're talking about this is it safe from a young age for someone who's 14, 15, 16 to go on to some of these contraceptive pills in order to alleviate these symptoms, these kind of cramps?
Yeah, so we do think it is safe. And I think that, unfortunately, hormonal contraception gets a very bad rap on social media because fear sells. And if you think about the risk to you medically of having untreated painful periods. So people just think about, oh, well, you're missing school. But we know that people who have very severe period pain are more likely to develop other pain conditions in their life. And that we think that early exposure to severe pain can prime the nervous system in a way to actually heighten the pain experience, meaning it makes you more likely to develop other pain conditions. So could we be setting somebody up for more likely getting migraines later in life? Could we be setting them up for other medical conditions by undertreating their pain? Never mind if they have to miss 2 days of school a cycle, then that could affect their academic performance, which could affect getting into the university they want to go, could affect their job performance, could affect their career. So it's really important for people to think about this, not just as, well, it hurts, but which is important itself to treat because people deserve to have their pain treated. But what are the ramifications of untreated pain, right? So then you think about it from that standpoint that the birth control pill, the IUD, the Nexplanon, they would all be a net positive. And so we think that they're very safe to be on. There is some conflicting data on the risk of depression related to starting hormonal contraception. And the data is very conflicting. And there are some studies that show that there could be an association for some people and some studies that show that it isn't. If we say maybe it could be, if we err on that side of caution, then the incidence of depression associated with the pill for teenagers might be 1 in 200. But that's not certain. It absolutely could be less than that. And I think one of the problems with the data is, so people start the birth control pill because of something. They don't just like, I'm totally fine and I don't have a new partner and I'm just going to go on the pill because. So teens can be in domestic violence situations, right? So starting the pill could be part of that. They could be in a relationship that's having an impact. They could be starting the pill because they have PMS, which is associated with mood disturbances. And maybe they actually have depression and not PMS and has been misdiagnosed. So they're not getting their depression treated. Polycystic ovarian syndrome, which is a reason many people go on the pill, is associated with a higher risk of depression and suicide. So it's very difficult to study. It's an active area of research. But I think that people always have to look at the reason you're going on. And there is a massive impact of untreated pain. And, the idea then what are we supposed to do? Just let kids curl up in the corner and that's not a solution.
Yeah.
Jen, we're running short of time, but I do want to pick up on this comment that you talked about earlier about the iron deficiency, because you described something like 40% of girls under 22, which sounds huge.
It is, yeah.
And I've got Sarah as well. So both of you here, I really want to make sure we follow up. That sounds like very actionable advice. Like, what can you do about this?
Yeah. So if you are someone who menstruates, and you have symptoms like fatigue, brain fog, hair loss, you just don't feel right, you need, and you get a period. So if you're somebody who hasn't had a period for 5 years because you've got on a hormonal IUD, then, you could have iron deficiency for another reason, but most of the younger ones are related to menstrual. You need to not just get a blood count to check for anemia. You need to also get a ferritin level. because a ferritin is a reflection of the iron stores in their body. Because you don't want to be brushed off. You can have a normal blood count and not have anemia, and still have severe iron deficiency. I diagnose that maybe every single day in my practice because iron deficiency is associated with a lot of other symptoms. So I'm often testing people because of those other symptoms. And the number of women that I identify every week, who have iron deficiency is pretty staggering, which fits with the data that we see. And so I think people need to get their ferritin level checked. And if their ferritin level is low, they shouldn't accept that that's normal, that that's okay. It needs treatment. And if oral iron's not working, then there's intravenous iron, which is actually really very safe intravenous iron now. And also, the reason for the iron deficiency needs to be investigated. So someone needs to ask you about your periods and if you're soaking pads, if all these things, because there's treatment for heavy periods as well, and their investigations may need to happen too.
You talked about oral supplements of iron, and there's some fascinating research coming out now to show the benefits of, if you are taking iron supplements, of having them every other day. There's a particular chemical that increases when you have an iron supplement that actually prevents you absorbing too much of the iron, because again, our body's really clever mechanisms to make sure we don't iron overload. And so actually, if you can miss out a day, means that you'll then absorb it 48 hours later. Yet if you're having it every day, this particular chemical that stops the absorption is at its peak and then blocks the absorption.
I'd like to try and do a quick summary, which we always do. It was quite complicated, so please correct me where I got any of this wrong. So we started talking about why do people menstruate at all? I hadn't realized we were in this very small group of animals on this earth that do this. So something quite special. And you were explaining that we have this cycle that is really about preparing sort of the lining of our uterus in order to deal with this obviously particularly difficult human fetus compared to all the other fetuses that are out there. And so we build this line, which I think was a decidua, did I? And once you do that, it's a one-way ticket. So you create this, and having done it, it's like, well, if you aren't going to get pregnant, then our bodies kick off this system and says we've got to get rid of it. It peels off. And actually what's happening is the bleeding is when this peels off, which makes sense, like sort of ripping something off your skin. And so it's normal blood that's coming out. And there's this process that's sort of pushing this decidua and the blood out before you start the cycle again. You then said, look, there's a lot of myths around this and things that you shouldn't accept. So if you're having heavy bleeding, that isn't normal. You should be going and seeing your doctor. It can lead to iron deficiency. I think you said 40% of women under 22 are iron deficient in the US, which is a huge number, no doubt partly affected by the diets they're all eating as well. You then went on and said, lots of pain is also not something to just accept. And again, something you should go and speak to your doctor about because there are things that you can do. We then talked a bit about sort of the differences in the cycle, about how it affects how you're feeling and some of the symptoms you have, and that particularly the second half of the cycle is what's associated with all of these different experiences. So you can be hungrier. That's true. You can have these food cravings, especially for sort of carbs and chocolate. Yes, stress can impact that, but you're describing it's not like the stress of doing an exam. It's got to be at a really high level of stress. Then we talked about PMS, premenstrual syndrome, and you said 70 to 80% of people who are menstruating experience this. So it's a huge number of people. Again, it's in the second cycle, and the duration varies. What could you do about it? So you said, interestingly, you started with exercise, so that is real. It's not made up. Birth control pill can have a really big impact. And we had a conversation about whether it was safe even for adolescents. And I think, Jen, you're saying, yes, I think it's safe and actually, in many cases, a good solution because these impacts are all very serious. An antidepressant can actually help while having symptoms. And a healthy diet can also be having an impact. We sort of finished off talking about iron deficiency and what could you do. And I think, Jen, you said literally every day in clinic you're diagnosing somebody with iron deficiency. This is not sort of a really rare occurrence. It sounds like there are a very large number of people who may be listening to this podcast, or their children or whatever, who could be with that. Then in terms of supplementation, interestingly, popping it every day is not as good as every other day, which I think is very counterintuitive. And then in some cases, if this isn't working, you may actually have to go to having something intravenous. Did I manage to capture that okay?
Yeah, I think that's a really great summary.
Jen, thank you so much for coming in and taking us through this little summary of what came out of the book. And I know we will have many follow-on questions, so I hope we might be able to get you to come and join us again in the future.
Oh, I'd love to. This is great. Thank you so much for having me.
No, I have learned so much, so thank you.
Thank you.
It's a pleasure. Thank you very much. I hope you learned something today and enjoyed the episode. If you listen to the show regularly, you probably already believe that you can transform your health by changing what you eat. But now, there is only so much you can learn from general advice on a weekly podcast. If you want to feel much better and live many more healthy years, you need something more. And that's why each day, more than 100,000 members trust Zoe to help them make the smartest food choices, so they could feel better now and enjoy many more healthy years. Combining our world-leading science with your Zoe test results, Zoe is your guide and coach to sustainable improvements to your health. So how does it work? Zoe membership starts with at-home testing to understand your unique body. Then Zoe's app is your health coach, using weekly check-ins and daily guidance to help you shift your food choices so as to steadily improve your health. I rely on Zoe's advice every day, and truly, it has transformed how I feel. So, to take the first step towards the possibility of more energy, less hunger, and more healthy years, take our quiz to help identify changes to your food choices that you could make right now. Simply go to zoe.com/podcast, where as a podcast listener, you can also get 10% off.